where early detection, teaching, and preventing chronic conditions really plays a role, right? So we're moving from a reactive role to a proactive role, right? So when they come into the hospital, we're in a reactive state, right? We're reacting to an illness that they already have or that they're presenting with, right? Whereas with health supervision, we're really looking at preventing those things from happening so we don't have to move into a reactive role, okay? So there are three components of it. The first one is that developmental surveillance, right? So we're looking at all of those developmental milestones. Are they hitting them when they should be? Are they maybe delayed or a little bit slow in reaching those things? Why are they delayed? Why are they a little bit slow? Or are they hitting them all when they should, right? So that's the developmental surveillance piece. And then we're looking at the injury and disease prevention, okay? So injury prevention, this is more of your teaching, right? Here's what your child is doing, here's how to protect them, here's what they're going to be doing next and how to protect them in that stage, right? So that injury prevention. So really looking at, for like infants and toddlers when they start to walk, right? Injury prevention includes what? Okay, education around safeguarding your house, right? So if you've got stairs, baby gates. If you've got, cabinets where you're keeping chemicals, baby locks, all of those sorts of things. All of those are gonna prevent injury, right? Disease prevention, this is our focus on vaccines, right? What can we prevent by giving them something to prevent a disease, okay? And also just keeping them healthy in general. Education around like hand washing, good hygiene, things like that. That will also prevent disease prevention. But really looking at, when it comes to the disease prevention piece of that, really the biggest focus is those immunizations and getting those when they should, okay? And then health promotion, so this is where we're really encouraging those healthy habits, healthy lifestyle, healthy diet, healthy exercise, right? Not just sitting behind a screen, okay? And noting that just because they're behind a screen or maybe they're very studious and they're doing homework and reading, that can also lead to an unhealthy lifestyle, right? So it might not be that they're like a gamer, right, and they're gaming and becoming unhealthy, but those who are are not so active, but like learning and not getting out and doing those things also can lead to a unhealthy lifestyle. Cool? So, where do we see them where we can look at health supervision? We kind of already touched on this a little bit, right? Those different areas, like the physician's office. That's our biggest piece, right? So when they come in for those well child visits, because again, in general, children are pretty what? Healthy, right? So a lot of the time, the only time that a physician might see them is when they come in for their well child visit, right? But there are other pieces of that team that you might not think are part of that team, but are crucial. So like at freestanding clinics or community clinics, daycares, schools, right? They have a school nurse, do they not? They should, or someone who steps into that role. So they should be aware of those things, like, hey, maybe this child isn't like where they should be and there's some issues, right? So we need to take a look at that, okay? When we're looking at health supervision, it's really important, again, to take into account those cultural aspects of things, because that's really going to guide your, again, your individualized care plan, right? What I consider a normal healthy diet might not be the same as what someone who's from like the Mediterranean area might consider a normal healthy diet, right? Those cultural differences, those backgrounds, and what foods are relevant to them and their culture are going to look very different, right? So how can we use those pieces but still make sure that the child is healthy, right? Okay. Community influences. So the surrounding community strengths, weaknesses, all play into how healthy a child is, right? So if there's clinics all over the place and there's easy access to healthcare, are we going to see healthier kids?
Yeah, maybe.
Maybe, right? Maybe not. Depends on if they go there. But in general, if health, yeah,
Stuff like that.
yeah, right. So if there's parks and there's healthy community areas for them to get out and be active, in general, we're going to see that they're healthier, right, than areas that don't have those things. Okay. Chronic illnesses. This is huge, especially for our kids who have like CPMR, right, or cerebral palsy mental retardation. So our kids who they're chronically ill, they're not up, they're not mobile, they're bedbound, right? So how easy is it for them to get to a healthcare provider if they need it, right? It depends on where they're at. Is the community that they're in a community that has access to all of those things, or again, are they like, do they live down in Yuma and all of their specialists are up here, right? Okay. International adoptions also have unique needs in that they don't have the same diseases and stuff that we have here, right? They have lack of healthy, clean water, right? Or their food sources are maybe very scarce, right? So when they come here, their challenges are going to be a little bit more unique, okay? What are they going to need that's different than someone who was born here and grew up here, okay? We kind of touched on this piece a little bit when we're looking at like getting that comprehensive history, right? Those socioeconomic pieces. We're looking at psychosocial pieces. So, do they have insurance or are they uninsured? Do we need to figure out a way to get them insurance? We had a family who was a refugee family, had no insurance, and their child was diagnosed with a neuroblastoma. In order for that family to get insurance, the hospital hired the dad, right? We found a way to get him a job and get him insurance to be covered for the care that their child was going to get. Right?
Or our one from Mexico. The uncle took over guardianship so he could put her on his insurance.
Yes.
So she could get.
So internationally, came here from Mexico. The uncle who was a citizen here, had insurance here, took over guardianship so that he could then put her on his insurance and take over care.
And they were visiting here.
Yeah, I haven't
Dad
heard.
is still in Mexico.
Yeah. So you might have to get unique, right? But it's important. That's why it's important to ask those questions. Like, what do you need, right? And making sure that we can find those things and what we can do for the family to get the best outcome. We talked about transportation. We talked about financial stress a little bit. So maybe they can't work or they have to go to work, right? So they can't stay with the child. Is that okay? Yeah. We encourage them to stay, but it's never pressured that they have to stay, right? We love hanging out with the kids at night when their parents aren't there. We have so much fun. Especially the little babies, because we just sit at the desk and hold them while we chart and do all sorts of things. They get passed around. It's a lovely time. But we do find that sometimes the parents can't stay, right? Because they have to work. Maybe they're a single parent and they only have that income, and you know, if it's just them, maybe they've taken their max amount of time off already and they can't do it. So looking at that financial stress, what can we do to help them, right? Encourage them to stay, but they don't have to. Okay. Family coping. We can help them with some of that stuff. Child life is another resource that can help them with family coping, right? Bring them in, let them talk, right? We also have case management, we have social work, chaplain, right? If they have a special like religious leader or cultural component that they want to bring in, can they do that? Absolutely. If that helps them cope and it's not interfering in any way, absolutely. Okay. So during the health supervision visit, we're going to do our history and physical, right? So we're going to gather all of that data, and we're going to do our head-to-toe assessment, we're gonna look at their developmental assessments, their behavioral assessments. Again, are they doing the things that they should be doing for the age that they're at, and their developmental stage, right? Where are they at? We're gonna do some sensory screening, so we're gonna assess their hearing and their vision, right? So, you know, obviously in our little kiddos, it's a little bit harder because they can't tell us what they're hearing and seeing, but when they get older, we're gonna have them look at the Snellen?
Yes, the vision.
Snellen chart, yay! Looking at that vision chart, right? And seeing what their vision is, right? If they have issues with their vision, we might also see that they have issues where? Their environment, sorry. At school, right? At school. So if they can't see what's on the board and they're not able to take in what the teacher's showing them, are they going to suffer in school?
Yeah.
Probably, right? Same if they can't hear it and they're sitting all the way in the back, right? Or you've only got 50% of your hearing and you have to keep turning to your left to hear anything. So we can see that they have issues in school, right? And then that at-risk screening. So again, with all of that data that you're taking in, what are they at risk for? Are they at risk for nutritional deficiencies because their family can't afford it, right? Are they at risk for such and such whatever, right? Because their family has some aspect of data that we collected that puts them at risk for something, okay? And then following that with immunizations, okay? We'll go over the immunization chart. I'll show you what I want you to know about that. We will utilize that, okay? And then finishing it with health promotion. So again, reiterating healthy habits, healthy activity, healthy eating, right? Because the more times we go over it, they're going to have what? More exposure, better outcomes, right? Better compliance with everything, okay? Better health literacy, right? All of those goals that we wanted to hit and those outcomes, right? Okay. So those at-risk screenings that we want to take a look at, and really they only dive into these if there's an indication that we need to dive into them. It's not a routine thing that we're going to look at. So if there's issues with the growth chart, right, and we're looking at where they're at and we're like identifying that there's an issue there, we might go dive into that metabolic screen, okay? If they're not doing so good in school and you have parents who are saying, my child keeps saying, huh, what? Or just stares at whatever and doesn't hear me, do they have selective hearing or do they actually have a hearing issue? My son has selective hearing. I will ask him something and then like a minute and a half later he'll be like, I want a burger for dinner. Okay, I asked you that like 2 minutes ago, right? So only if they have a concern will they really dive into it a little bit more to see if that's an issue, okay? Iron deficiency anemia, again, for like our kiddos who might have like an absorption disorder like Crohn's or celiac or something like that, or if you've got individuals who have heavy menstrual bleeding, or that's going to put them at risk for iron deficiency anemia, right? Same with the other ones, right? Lead screening. If they live in a house that's older than 1960, I think it's like 1960 is when they stopped using lead paint. So newer houses, not really an issue, but older houses, I want to say it's before 1960. If they live in a condition where that might be an issue, we'll test them for that. And then like hypertension, hyperlipidemia, so if you've got overweight children, stuff like that, we want to make sure that we're screening for those things, as well as scoliosis. So scoliosis, we'll go over that in musculoskeletal when we get to that point, but it's part of their well child visit. It's super quick. How do they test for it?
Bending over.
Yeah, they just bend them over and run their fingers down their spine. Do they go in a straight line or do they deviate while palpating the spine? Okay. That developmental surveillance, so again, listening to parental concerns, okay? Noting and address any concerns that they have about their child's development. So, they might approach you during a well-child visit and say, hey, I'm at a mommy and me group, and the other kids their age are doing these things, but my child is not, okay? Is that a concern? Yeah, but knowing about their history, say, yes, chronologically, they're 12 months, but maybe they were born 2 months premature, so those other 12-month-olds who are doing, XYZ, that's where they should be. But should that premature kid be there yet? No, so that's where a lot of that education is huge, right? Educating them that, yeah, chronologically they're the same age, but developmentally they are not, right? Okay. Same thing, developmental history, obtaining the detailed history of the child's developmental progress from birth to present. So have they been on a steady path and then something happened and they regressed, or have they been steadily moving forward, right? That is another issue. So if they've hit milestones and they're no longer able to do that thing, is that concerning? Absolutely, right? They should continue on and build upon those milestones versus hitting that milestone and then regressing and then not being able to get back to that point, okay? Did they have some sort of injury that impeded them and set them back? Did they have some sort of infection that did the same thing, right? Or is there some other issue that's going on, okay? We want to make sure that we're doing accurate observations. So if we've identified that there's an issue, there is a Denver developmental screening tool that we can use, and it assesses like 200 different like milestone aspects, from like physical things to cognitive things. Can they stack a block on top of another block? Huh? It's the Denver developmental screening is what it's called. And so like they'll look, so at the top it has their age, and at the bottom it has their age, and they'll draw a straight line down. Do I have that on there?
I don't think so.
Let me take that off. But they'll draw a straight line down, and essentially everything to the left should be something that the child for that age has either already accomplished or is in the progress of accomplishing, and everything to the right is everything that should be up and coming. So there are some bars that will fall like right on that line where some kids of that age have already started and some kids have not yet started, but it's an average of where they're at. So they should be working towards those things. And so if they're going through and they're finding that everything is to the left, or there's a number of things to the left of that line, that kid has a developmental impairment, right? And then we need to work on getting those early interventions, right, to help them. Okay?
I took it off.
I think I did, yeah.
It's a lot.
So later hearing risk, we kind of already talked about this. So observe for signs of hearing difficulty. So like when they're on the phone or in noisy environments, like do they have issues hearing? Are they saying huh a lot or what? Asking you to repeat, those are issues. Volume levels are huge, so that's an indicator. So if the child has to like crank the volume all the way up to hear it, that's not normal, right? They should have it at a much lower level, okay? Using the vision screening chart, so we're gonna make sure that we've got the right chart based on their age, that it's at their eye level, right? So looking forward, it should be right at their eye level. It shouldn't be like way up here, it shouldn't be way down here. We want it straight ahead, okay? The distance is gonna be anywhere from 10 to 20 feet. We're gonna ask them to stand on the line, cover one eye, cover the other eye, and read the chart, right? And that chart starts with larger letters at the top, and they get smaller as it goes down towards the bottom, right? And so we want to see how far they can get down there and clearly read what's there to determine what their vision is. Okay? Okay. Injury disease prevention. This is not a complete list, but this is a nationally notifiable disease list of common ones that we will see. Okay? The ones that are bolded and italicized are the ones we're going to focus on. Okay? So you don't need to know all of these. So in that near pod, there was a number of communicable diseases that were in there, right? Review those, just kind of get an idea of what you're looking at. But influenza, meningococcus, strep, and varicella rotavirus are the ones that we're going to focus on, and pertussis. Thank you. So meningococcal we'll go over when we get to neuro. Pertussis we'll cover in respiratory. We'll also cover the strep in respiratory, and we'll go over varicella rotavirus today. Okay. Okay. Viral exanthems. These are just widespread rashes that go along with a certain viral process. Okay. Depending on the viral process, there's a rash that goes along with it that you can tell, like when they come in, like if they've got like the slapped cheek, that is Fifth's. Is that right? Fifth's disease. Where it looks like you essentially slap them, right? Like the caregiver slapped them and it's just this red cheek rash. It's very specific to that disease process. Again, really only need to know the varicella.
It's
Fifth's, thank you. Okay. Types of vaccines. I'm not going to test you on the different types, just know that there are different types and what they're used for. So we do have live attenuated vaccines. So do you know which ones are live?
The ones that have, which one?
Which ones specifically? So like MMR and varicella are live ones, okay? So it's important to note and know that if you're dealing with like immunocompromised patients, they cannot have the live attenuated ones, right? So if they are exposed to, say we have an immunocompromised oncology patient, right? And their sibling contracts, bless you, chickenpox. Our patient, our oncology patient, cannot get the vaccine. What they can get is IVIG. So we're essentially giving them the immunity against it in a bag, in an infusion, right? The immune globulin, right? Because their body isn't going to be able to make it to fight it. So we're going to infuse those antibodies into, or that immune globulin into that patient to protect them against it, right? As well as making sure they stay away from their sibling and respect all of like the isolation sort of stuff, right? You've got one, and when we think about vaccines too, typically we think about them just being against viruses, right? But we have ones that are against bacteria as well. So we will do an inactivated toxin or a toxoid vaccine that prevents against specific bacterial infections, like what? What's the most common one? Meningitis. Yep. So your meningococcal one. Okay. Cool. Okay. So this is the vaccine chart. It does say 2019 up there. It doesn't change. Okay. Every year it is the same. The only thing that changes is the date. Huh? It's not really going to change much. It might look a little different, but hopefully it'll stay pretty close to the same. So for this, you just need to know what's in yellow, okay? And for the ones that have dose ranges, you're going to combine it with other ones kind of in the same column. So like your Hep B, your second dose, there's a whole bunch of other ones at 2 months, right? So you're gonna include that Hep B with all of the other ones at 2 months, okay? With your, same with Hep B again at 6 months, so see how there's a range and it starts at 6 months, but there's a whole bunch of other ones that start here as well, and can be given there. Your IPV is also gonna be given at 6 months, okay? Does that make sense? Clear as mud?
Yeah.
Okay.
I need exposure one more time, I get it.
Okay.
So she does get it.
Perfect. Okay, so if I were to ask you at 2 months, what vaccine is your child gonna get, right? You are going to include Hep B at 2 months along with all of the other ones that are there, okay? If I ask you at 6 months, what are they going to get? You're gonna do the same thing. You're gonna include Hep B, even though there's a range up to 18 months, it's going to be included at 6 months. So the reason that they are that way is because there's a well-child visit, right? So at each one of these, there's a well-child visit that coincides with all of these vaccines, okay? There is some flexibility with like the Hep B and the IPV, but they try to do it with all the other ones. In most of the time, they're combo vaccines, meaning there's more than one in one injection, right? So they're not gonna get, so like at 2 months, they're not gonna get 6 injections, they might get 2. There might be 3 vaccines in each one, so they're gonna get one on one side and one on the other side, right? It's not 6 different pokes. It's not 6 nurses all with a needle and saying, all right, go, right? No, they are combo vaccines. So there is, again, some flexibility with those, but for the most part, they're gonna be given with all of the other ones at that time frame.
For the test, are we gonna have this chart or do we have to like, no,
You need to know it.
all of them?
The yellow, just the yellow. Because the rest of them are like, if they've got like a modified schedule or like they're compromised or something like that, okay? You just need to know the ones in yellow, okay?
Of the ones that are only a range, like the measles, mumps, should we go with 12 months or should we go with like 15?
So your measles, they'll go at 15, there.
For measles, varicella, and hepatitis
Yep,
A?
all of those there. So you're gonna start here, so this one, so your DTaP is at 15, and so they're all gonna fall in there, okay?
But if you ask us about 12, we can do those in 12, right?
I won't ask you that one.
Oh.
Okay, cool. Okay. All right, so you've got a parent, Christina, and her, no, just kidding. You have a patient, Christina, who's 6, and she's coming in today. Mom is calling the pediatric clinic and wants to know this. Calling in because she's concerned that Christina's recent exposure to chickenpox or varicella. She was exposed because she attended a birthday party 8 days ago, and the host child developed the characteristics of varicella rash 2 days after the party. And Mrs. Acton wants to know what signs to watch out for and whether Christina should be placed or should be kept home from school. So Christina attended a birthday party 8 days ago. The host child's parent informed the attendees that her child was later diagnosed with chickenpox. Christina is currently asymptomatic, no fever, rash, or malaise reported. Mrs. Acton states that Christina has been eating, sleeping, and playing normally, and Mrs. Acton denies any recent travel or exposure or other sick contacts. Okay, seems pretty straightforward. Yeah? Okay. She's up to date on her routine immunizations except for the second dose of varicella vaccine, which is due last month but has not been scheduled yet. She has no history of infection and no chronic illnesses or immunodeficiency. She lives at home with her 2-year-old brother, who has not received any varicella vaccines yet. Both parents had chickenpox as children, no smokers. She attends first grade. She received her first dose of varicella at 12 months. The second dose she missed, which was due last month. The exposure timeline, day 0 was the day of the party. She attended the party. 2 days after, the host child developed the rash and is diagnosed with chickenpox. And 8 days after the party, Christina remains asymptomatic. The mother's concerns and questions are as follows. Is Christina at risk for developing chickenpox despite 1 vaccine dose?
Yes.
Yes.
Yay? Nay?
Minimal risk.
Minimal risk.
Have exposure to when symptoms are present. With chickenpox.
Okay. So, yes, so there is a few things we need to know first, right? What is the incubation period for chickenpox?
AI says 14 to 16 days.
10 to 21 days from day of exposure.
Oh, yeah, you raise
Right.
from 10 to 20 days.
Okay. Knowing that, and her vaccine history, is she at risk for developing chickenpox despite 1 vaccine dose? Yes. However, is her risk reduced because she got 1?
Yes.
Yes. So it offered that 1 dose offers about 80 to 85% protection. Okay, so there is still some room for breakthrough. Okay, but she's at a much reduced risk because she's already had 1. Okay. Does she need to stay home from school during the incubation period? When does it actually become contagious?
When it's symptomatic.
When she's symptomatic. So she attended a party of a child who didn't have symptoms, right? So could she have contracted it?
No. Unless there was another kid at the party that did and it's just.
Right. Yes. Okay. If she delays symptoms, what does Mrs. Acton need to do?
She needs to do something with the other baby.
Isolation.
She needs to do something with the other baby, right? Like what?
Oh, cause he don't have the vaccines, right?
What'd you say?
I said get him out.
Get him the shot.
Get him out of the house.
Go get him.
Get him out of the house. Because chickenpox is what?
Airborne.
Is airborne precautions, right? So them being in the house puts that child at risk, right? Because he hasn't gotten his vaccine yet. Okay. So that kind of goes into the next one. Is her younger unvaccinated sibling at risk?
Yeah.
Absolutely, right? Because he hasn't got it yet. Okay. Can Christina still get her second dose of varicella vaccine now? Yeah, absolutely. She doesn't have any symptoms, and getting it gives her that much more level of protection. Okay. Good.
Yeah.
Okay, so going through looking at some common pediatric skin conditions. We've got impetigo, scabies, lice. Is everyone all itchy now? My favorite thing to talk about. Okay. Impetigo, that's a highly contagious bacterial skin infection, often caused by staph. Most commonly seen in kids who attend what? Daycare, right? We see this a lot in daycare. It spreads like crazy. That impetigo.
Yes.
Yeah. Scabies, this is a mite versus a bacteria or virus, right? And so it's a mite that gets under the skin, lots of itching. How do we treat it? Sorry, let's go back to impetigo first. How do we treat that one?
Is it like the hand, foot, and mouth?
It's different, but similar. Yeah, in that it's highly infectious and contagious, and we want to contain it as best we can. With impetigo, because it's a bacterial skin infection, we can do a topical mupirocin for like 5 to 7 days, 3 times a day. Okay. What about with scabies?
Topical, like a lotion, but
Yeah, it's called a scabicide. like an insecticide, it's a scabicide, right? So they're gonna present like super itchy, right? The itching isn't actually from the mites burrowing, it's from the defecation that it leaves behind that caused the irritation. Yeah. And it will spread. It is all over. So this scabicide that they're going to use, it's really important that they follow the directions to the T and they cover every surface of the body. Because if they miss anything and there's mites in that area, even though they treated everything else, the mites will then spread from there. So they have to make sure that they get like in between the fingers, in between the toes, all over, right? All the little creases everywhere. Okay, they want to make sure that they get it. Yes. Right? It spreads easily through contact. So again, daycares, schools, right? Same with lice. Right? It's, I don't know, like I don't think my.
I work in a daycare and I haven't seen any of these. We've seen hand, foot, mouth.
Nice.
Ringworm. Oh, lice is out
Not
there.
so nice.
But we get kids with it.
Occasionally, they don't report it in school like they used to. I will, yes.
Oh, our school does.
So they,
for sure.
because I asked about it not too long ago, and they don't post it like they used to. They just go on about their day like it didn't happen. We do see it inpatient. Sometimes with our kiddos who come from like lower socioeconomic areas or from the reservations a lot, they will have it. And it's almost sometimes like they don't have the urgency to treat it like other cultures. It's kind of like a part of who they are, and if they have it, like that's what it is. However, when they come in, we treat it. We cannot let them stay in the hospital with it, so we will treat it while they're there. Yeah. Okay. So with lice, it's the special shampoo with the fine-tooth comb. You're gonna go through. You're gonna pick. One of the easiest things to do is to shave their head, because trying to get lice out of your hair would not be easy. Multiple treatments, right? And it's the child gets irritated. They get frustrated because you're like having to like pick through their hair. It takes a really long time. So it's really unfortunate, especially for girls who have long hair, because it is a part of who they are. But to just shave their head and then do the shampoo treatment, right? For boys, not a big deal. They shave their head, right? It is what it is. But for girls, it's a part of who they are, right? So then they might need like a wig or something after, right? Or you can sit there for however long it takes to do multiple treatments. Yes, hours and hours, right? Because we want to really prevent a reinfestation, right? So we want to make sure that we get everything, that we killed everything, okay? All right, so healthy promotion. So when it comes to health promotion, this is where that anticipatory guidance comes in. So again, what is your child doing? What do they need to be doing for the health promotion, for those best outcomes, right? So we want to focus on oral health, right? Making sure kids are brushing their teeth morning and night, that they're going to the dentist. How often? Every 6 months, right? Okay. That they're maintaining a healthy weight. So provide guidance on how children can maintain a healthy weight. One of the things that we kind of encourage is, if they have siblings and one of, our patient is maybe overweight and their siblings are not, or even if they are, we will encourage them to create like a family exercise schedule. And so that one night of the week, one of them is picking something different. And everyone has to be involved, right? You might not like what your brother picked. He might not like what you pick, but you're going to do it together, right? So the biggest thing is getting them up, getting them out, and getting them active.
With like the healthy weight and healthy activity, with like enrolling them or giving them information about like a sports team, like recreational.
Absolutely. Yeah, find out what the kids' interests are, right? Maybe they just haven't been exposed to a sport that they like, right? And so maybe through like their city, bless you, through the city, they have like the city sports programs, right? And, so and maybe they can't afford it. So maybe that's a socioeconomic thing that you might have to help them with. Is there a resource that we can get them to participate in something where they're up and active like that? Is there a way that we could get them like to a community center and work out there or do something active there, right? Anything that you can think of to get them up and active, right? One of the things that we don't want to do though is have them record like their daily weight, right? Because that's going to mess with their head, right? And so continuously watching their weight every day, they're going to get hyper focused on that. And then that can cause some psych issues too if they hyper focus on that and they're like, oh my God, I didn't lose as many pounds today as I did yesterday, or last week, or this week I've plateaued, or I've put on weight this week, right? But depending on what they're doing to get up and active, like if they're weightlifting or something like that, if we haven't educated that losing fat and putting on muscle you might see your weight go up, but are you more toned than you are fluffy, right? I am definitely more fluffy too. Putting these pants on today, I was like, ooh, I am not what I was when I got married. Personal hygiene. Encouraging good personal hygiene practices such as hand washing, right? Hand washing is huge. We want to prevent infection, spread of infection, but also, are you showering? Right? Those teenage boys, middle school boys, I don't know what it is. They just don't want to shower. Like, why don't you want to shower? Right? Lucas puts up such a huge fight trying to shower, and it's like there's a lot of screaming and crying and fighting. And then once he gets in there, he's like, this is fine. And he just loves it, right? He just stands there. But then he'll come out 15 minutes later and his hair is dry. And it's like, what did you do in there? Did you wash anything? Did you use any soap? And he's like, yeah, but I dried it already. And I'm like, no, you didn't. I was like, you still have the same stick up you had this morning. You didn't wash your hair.
How old is he?
He's 9. I talk about him a lot because I have a lot of references to things. So you'll hear a lot about him as we move through. But yes, so personal hygiene. And that really plays into a lot of stuff when it comes to their psychosocial development too, right? Because if you stink, are you gonna have a lot of friends?
No.
Probably not, right? You're gonna have a lot of flies, but you're not gonna have a lot of human friends.
Flies can be friends,
right?
Okay?
Flies can be friends. Right. So hygiene is huge, right? Because we don't want to get to the point where like their classmates are complaining about them and making fun of them, because then that just spirals into a whole bunch of other things, right? So how can we promote that, right? We want to make sure that they're showering, that they have the resources to like do their hygiene and stuff like that, right? And safe sun exposure, that is huge here, right? Because we have sun, 300 days a year, right? There's not many days where it's cloudy. We missed the most epic storm Arizona has had in a decade. Because we were in Rhode Island having fun at the beach.
It was beautiful.
It was beautiful. It was actually overcast and kind of misty, so it was kind of nice, but we missed the epic hail and stuff that we had here.
Oh, it was pretty overcast here.
Yeah.
We were watching it from our Ring cameras.
We were, yeah. We pulled up our cameras and we're like, oh, it's hailing, it's great.
I was driving home from here, and on the 10, it was like pitch black at 2 p.m.
That's crazy.
It's like, I had my brights on, could barely see a car 50 feet in front of me, just like, what the hell?
That's crazy. It's all because I talked you into going to a conference. All right. So safe sun exposure. So we do get a lot of sun here, right? We spend a lot of time in the pool. We spend a lot of time outside, right? But the sun is super intense, right? So when it comes to safe sun exposure, what time frame do they want to avoid being outside? Close. It's even earlier. 10 a.m. to 4 p.m. is like the time frame where the sun is most intense, right? And even maybe an hour each way is still pretty intense, right? So we want to make sure that they're applying sunscreen, that they're applying it often, especially if they're in the water, right? Because the water is going to wash it off. So frequent reapplication of sunscreen. Just sitting under your umbrella is not going to be enough, because the sun will reflect off the water, right? First summer here, I got the most epic burn because I was like, oh, I'm fine. I'm sitting under the umbrella. Didn't even think about the reflection, and I fried. I've never done that again. Touching on pediatric obesity, I know we talked about it a little bit already, but their excess body weight impacts their health, right? So this obesity puts them at risk for kind of comorbidities, especially type 2 diabetes, right? We've seen an increase in obesity. We've seen an increase in type 2 diagnosis in children, when we've typically have diagnosed that as an adult issue, right? So have you heard of Healthy People? healthypeople.gov, like Healthy People now is 2030, right? So every 10 years they put out objectives that the government wants to hit with healthy metrics. Childhood obesity was on for 2020, and when they evaluated the data, it actually went up instead of down with everything that they were doing. So childhood obesity hit Healthy People 2030 again as an objective, because we saw an increase of obesity and type 2 diabetes, okay? So it's really important that we catch those kids early and we start incorporating those early interventions.
Especially too, because they've been diagnosed with either or in childhood, that's what the rest of it.
Yes, and it's going to just, if we don't get them healthier, it's going to cause issues further on, right? With type 2, we can kind of curb it and reverse it, because it's usually a result of like their healthy lifestyle or their unhealthy lifestyle, right? For the most part. So if we get them to a healthy weight and we get them to a healthy diet, their diabetes is less of an issue, right? Unlike type 1, where it is an insulin dependent thing and we can't modify that, okay? Cool. Safe sexual health promotion in the pediatric population is also huge, especially in our older school age into adolescent, right? Because they're starting to explore, and they are getting out there and doing things. So we want them to be safe, right? So we want to provide that education. If they are going to do it, this is what you need to do, right? If you think you've had an exposure to something, where can you go get treated? Where can you get tested? Okay. We do have a vaccine for one of the STDs is just what? HPV. How early can they get it? 9. Do we want both genders to get it?
Yes.
Absolutely, 100%. Right? Okay. We are gonna dive more into this during simulation. We are actually gonna have a sex ed debate on abstinence only versus comprehensive sex education. Okay. Okay. I'm going to skip over this just so that we have time for everything else. Real quick. Okay. So when it comes to key pediatric nursing interventions, we want to make sure that we're doing our focus assessments, we're doing pain assessments, we're managing it okay, and that we're addressing their hydration, nutritional status, looking at their pharmacokinetics, right? Again, how it moves through the body is different than how it moves through the body in an adult. That we're doing accurate dosing calculations, okay? And we're gonna work on some here in just a second. Medication administration strategies. Are kids good about taking their meds?
No.
Absolutely not. Are there things that we can do to get them to take them better?
You put them in a headlock with this. Worried about their
Sometimes it's not great, and you do have to alligator wrestle them, right? If they have a chronic disorder and they're having to take things on a regular basis, it becomes easier. If this is the first time they've had to take anything and they're taking like Tylenol or ibuprofen, it could be a total nightmare. You could end up with it in your eye and then have to wear a face shield every time you have to go give them Tylenol. Been there, done that. But you can incorporate the parents, right? You can give it to them and have them give it to their child. You're gonna watch them do it, but they will do it because they feel more comfortable with their parent giving them something than some stranger trying to shove something down their throat, right? No. So she asked if you have to document that the parent gave it, but you were there. As long as you're watching them do it, you don't have to document that the parent gave it. No.
It's like
So they don't
that.
have to give the parent.
Well, you know that it was given because you watched them give it. Like, you're not gonna give them like the syringe and then walk away. Like, you're gonna watch them give it so that, and you know that they gave it because you're watching them do it. Because have you ever documented that like the parent gave it? There's not really a spot to do that.
I mean, you can always put a nurse's note or put like a right click, but I know
You could, but you're gonna watch them do it. Like, you're not gonna leave the med with them and then walk away, and then come back and be like, "Oh, it's gone. Did you give it?" And they're like, "Yeah."
Yeah.
No, you're not gonna do that.
I gave my daughter on Wednesday when she got her tonsils.
Is there like an increased usage of like liquid medications like the oral suspension?
Absolutely. We definitely use a lot more liquid in peds than we do pills. However, sometimes with like our oncology meds, they might have to take something that doesn't come in a liquid and they will have to take a pill. But that's where Child Life comes in, and they will work with them on taking oral medications. And so they'll use candy to work up to the size of the pill that they're gonna take. So they might have the child like swallow a Skittle or a Tic Tac or something like that. And if they end up chewing it, because it's candy, it's not a big deal, right? So we're never gonna try with the med. We're gonna try with like a candy of the same size to see if they can take it. But if a parent comes in and tells you like, my child's not gonna take a pill, like they don't take a pill, right? They gag on it or whatever their reason, that's fine. We can, if it comes in a liquid, we can get it in a liquid if we have it.
When, I forgot what my whole question was, but when they like, especially the oral, like the liquids, they spit out like half of it or whatever things that they do. Like,
Yeah.
how do you
So
determine, or like, okay, do I need more?
it's an unfortunate situation, but we're not gonna get more because we don't know how much of it they actually took.
Yeah.
For our younger kiddos, you're gonna do a little bit at a time and watch them swallow it before you put more in there. So if you've got like 3 mLs of a liquid that you have to give them, you might do like half an ml at a time, and then get them to swallow it, and then do like the next half ml. So it might take a little bit, but you're also gonna direct it towards like the back of their cheek, not directly back, because you want to make sure that it's going into they're gonna swallow it, right? It's gonna give them kind of that reflex to swallow instead of spit it out, right? If it's further back, they're less likely to spit it out than if you just put it like towards the front of their mouth. Okay.
They used to tell us that food is blowing their face. I mean, it works, so I'm saying when you blow it, you like forget it.
There was even this like, because you know they can't take anything a lot of times when they're little. My daughter had a bad cough, and I was trying to grow this like homeopathic cough syrup for nighttime so she could just sleep. She's like 3. And it's like dark colored, it's like homeopathic stuff. And I'm just trying to like get it back there, and she just spit it all over me, all over herself, and I was like, oh my gosh, child, please just take it.
It's not easy, but there are strategies that we can do. So like a little bit at a time, try to get it as far back as possible. I don't particularly like blowing in their face, but that is something that, especially like our younger infants, something about that like startles them and then they swallow. You can stroke their cheek. That also helps kind of kick in that like that reflex, that swallow reflex, to get them to swallow. Things like that. Okay. So trigger warning. These next 2 videos may elicit some strong emotion, but they are important to go through to demonstrate and kind of discuss why we do what we do, why we monitor what we monitor, and why using the equipment that we have is important, okay? Especially in the pediatric population, right? Really with any of our patients, but in our pediatric population, because an error on our side that could have saved a life is not okay, right? Especially with the peds, with a kid, right? So if you have to at any point and get up and step out, that's totally okay.
My daughter Leah was incredible. She was the life of our family. As I look back, when you see pictures of her and video of her, her spirit just comes through. She was alive. We never knew why she carried a purse. We used to tease her about it because she was so little to carry a purse, and then we found out it was because she had snacks for her little sister in the purse. And in the mornings when I'd get the girls up for school, and I'd always say, Leah, come on. No, Mom, I'm so tired. And I'd go in her room and I'd pull off the cover. She'd be all dressed. Her hair would be in braids. You know, she'd just be messing with me. But that's who Leah was. She just, she was remarkable. She had a pectus carinatum, which is where that people call it pigeon chest. Your chest comes out. And so every morning she'd get up and put on a t-shirt and, you know, be uncomfortable. I took her to a doctor and they said, well, you can do something about it, but they didn't tell me, like there was no need to, and that it was really a major surgery. So we did that, and a lot of things went wrong that day. So we went to the room, and she was on an epidural for pain. So they kept increasing her fentanyl and whatever to the highest amount, and she was in pain. So she wasn't getting pain relief if she was just getting her 80-pound body saturated with narcotics. My husband had to leave to go home to our other children, and he said to the nurse, I really don't want to get in anybody's business, but my child is way over-medicated, and I don't want anyone to give her more medicine. And the resident said, if you're not going to allow me to increase her narcotics, I'll give her something for anxiety, because she has to take deeper breaths. Maybe she's just scared of the pain. So it turned out that the resident had written an order for 2 milligrams of Ativan every 2 hours.
What's concerning about that?
That's a big dose for pediatrics.
That's a big dose for an adult patient.
Yeah, like,
That's a really big dose for a pediatric patient, right? 2 milligrams of Ativan every 2 hours on top of the fentanyl she was already getting, right? Okay. So she came out of constructive surgery. She was placed on that epidural with fentanyl and bupivacaine or marcaine to manage the pain. In the middle of the night, she was complaining at 2 a.m. Of increased pain. So they increased her dosage from 6 mLs to 8 mLs an hour. 6 hours later, she was still complaining of severe pain. So they increased that dose up to 10 mLs an hour.
She said it was through epidural?
Through an epidural.
Like,
Uh-huh.
was it not in the right spot?
That would be a good assessment to look at, right? If you're increasing an epidural and you're not getting the expected results, the first thing you should think is it's not in the right spot, right? So 6 hours after that, she was still complaining of severe pain. Dad expressed the concern. They ordered Ativan, 2 milligrams IV every 2 hours. Okay.
So it turned out that the resident had written an order for 2 milligrams of Ativan every 2 hours. And if you're familiar with Ativan, 2 milligrams of Ativan would put a grown man to sleep. She never spoke again after that first injection of Ativan. She was not on any monitors. I had been awake for 30 hours, and I remember sitting in the chair. It was midnight. I was watching Saturday Night Live, and I always remember Al Gore was the guest host, and I dozed off. And I woke up sometime around 2, and she was dead. I screamed, and they came, and for 40 minutes they're pounding on her chest to resuscitate her. And I'm sitting in the hall crying because I know she's dead. I've seen her. And I called my husband to come back, and I have a memory of my husband walking down the hall of the hospital, and I was sitting on the floor, and I looked up and I said, Leah died. He fell to the ground, and it took a couple people to pick him up and put him on a bed. And when I went home that day and told my other daughters, basically that was the end of our perfect family as we had known it. This was so avoidable. Had she been on a monitor, they would have detected that her breathing was deteriorating and the dose of narcotic was way too high, and something would have triggered an alert before she died while I was sleeping. And monitoring is so easy nowadays. I mean, the new technology is so simple, you know, and inexpensive and not invasive, and to find somebody dead in bed is inexcusable. 800 children will die this year because they're not on a monitor after surgery. That's so easy. You're not supposed to bury your children, and especially not healthy children.
Children a year because they weren't on a monitor. How easy is it to throw them on a monitor? So easy. We have one in every room. Every room has one. Hook them up, right? Do your assessment. So you ask great questions, right? Like, she had an epidural. Why were they keep increasing her dose with no expected effect, right? They just kept increasing it. So it was going somewhere, but not where it was supposed to go to effectively treat her pain, right?
There's so many things.
There are so many things.
The doctor prescribing that level of Ativan.
Yeah.
Not
So
being on a monitor.
do we follow doctor's orders blindly?
No.
No. Absolutely not. Just because they ordered that, your nursing judgment, your critical thinking, your clinical judgment, look at that. Is that appropriate for this patient? 2 milligrams every 2 hours for an 11-year-old child is way too much. We don't even order that for an adult patient. If I were to get that, I'd be out for a week. There's no way. That is so much, especially for someone who hasn't had exposure to that type of medication, right? They have no build up to that. And they gave it to her because she was anxious. Did you catch that piece? Yeah. That's why they ordered it. Maybe she's anxious. Maybe that's why she's not taking a deep breath. No, she's not taking a deep breath because you're not treating the pain, right? You're not treating the pain effectively. That's the issue, right? So many things that could have gone a different way if we did our focus assessment, if they had questioned those orders instead of just blindly following it. You have to look, is this appropriate for my patient? Because maybe when they first got there, those orders were appropriate for your patient, right? Depending on what it was. But now it's been 10 days. Is that 10-day-old order still appropriate for your patient? Right? We can't just keep going on what's there. We have to question and follow up with our physicians like, hey, I see this order is like 10 days old. Do we still need to have this one? Maybe not, right? What can we do different? Okay?
Lewis was our oldest child. We have 2 children. He was really a live wire. He was a very lively boy. He was also quite brilliant. He was one of the most highly intelligent people I've ever known. And he learned a lot. He knew a lot of things, far more than most adults. So he had this sort of wide and varied knowledge. And he also had a wicked sense of humor. So other children really enjoyed him. He was just a fun kid. He had a condition called pectus excavata, which is a condition in which the breastbone doesn't really grow straight. It's a cosmetic condition. We saw an article in our local newspaper talking about this safe, minimally invasive knee surgery. And we ended up taking our son for pectus surgery. And Lewis came out of surgery, and we thought, we've made it through that. About 3 days after surgery, he suddenly had this excruciating pain in his upper abdomen.
Okay, so what do you think's going on? What can cause an excruciating pain in the upper abdomen? Okay, maybe clot.
Pulmonary embolism.
What?
Maybe pulmonary embolism.
Okay, maybe pulmonary embolism. What else did you guys say? Okay, maybe pancreatitis, right? So differential diagnoses, right? What can cause pain up there? A lot of things, right? Okay. So he was in for elective surgery for the pectus excavatum. 3 days post-op surgery, his pain was not well managed. Opioid, he's getting an opioid via the epidural, and then they added Toradol injection every 6 hours. What class of medications is Toradol?
It's very powerful NSAID.
Okay. So now think about the upper abdominal pain.
So is liver's failing.
Liver or
What's a common side effect of NSAIDs? Bleeding, ulcer, right? Okay. So he was getting a Toradol injection every 6 hours. His pulse ox kept alarming. He's now complaining of excruciating abdominal pain. On a scale of 1 to 5, he was saying 5.
And they dismissed it as constipation. By the next morning, he had no blood pressure. He had sky-high pulse rate. He lost 2.8 liters of blood. And for a child his size, I think he had about 4 liters altogether.
2.8 liters of blood. He bled into his abdomen. was dismissed as constipation.
When his O2 was,
Oh. It gets, yes, that piece gets a little more intense. But knowing what meds your patient's on, knowing what side effects they can cause, and correlating that to clinical signs that you're seeing is huge. Again, that's where your clinical judgment, your critical thinking come in, right? So if they thought it was constipation, could we have gotten an x-ray? Maybe, right? But looking at everything else, his heart rate's going up, he's not looking so good, right? When we're thinking of like, you don't DSAT from constipation, right?
Silencing the O2 alarms?
So the next morning, he was very weak but conscious, lacks color, unable to acquire blood pressure by 4 different staff in different instruments. So they shut the monitors off to allow him to sleep overnight.
What hospital is
At least pale and
He was prescribed a drug called ketorolac, which is an NSAID pain reliever, like aspirin. He developed a perforated ulcer because he wasn't properly hydrated at the same time. And no one noticed. He declined for 30 hours. You know, I watched the...
30 hours. How many staff members is that?
At least 3.
At least 3 different nurses.
At least 3 different nurses, if they're working 12-hour shifts, right? But not only that, your CNAs, right? Your physicians should be coming around and seeing this patient. So for 30 hours, he continued to deteriorate and nobody said anything about a change in condition.
They just turned off his.
The color drained out of his lips. It was just like water going down in a glass. And then turned the same color as his skin. Just all the pink left his lips. It's really hard to even imagine seeing something like that. And then he said to me, it's going black, and he went and took cardiac arrest. I ran out of the room. I thought he was having a seizure. I ran out of the room looking for help. These residents and nurses were just astonished, and they worked on him for about an hour and a half before they gave up. But they never could bring him around. Lewis was monitored, but it kept alarming, and they would keep setting it lower and lower. And finally they had it down at 85, and it still kept alarming. So they turned it off. Every patient deserves continuous monitoring. You never know what's going to happen, particularly with postoperative patients. Lewis is a prime example. He was a perfectly healthy child, which is why no one believed that he could possibly have anything wrong with him. So you need an objective observer like the monitor.
So he was monitored. Those monitors have parameters, right? But he kept dropping below the set parameter, so they kept changing the parameter so that his alarm wouldn't alarm. And when it did, they set it lower. And then it would alarm, and they set it lower, and then they turned it off. Why? Those are right? This is something that both of these cases are something that should not have happened, right? Leah should have been on a monitor to begin with, and he was on one, and they kept setting it lower and lower and then turned it off. And both of them ended up with a not good outcome, right? They both passed away. Both of them, were they preventable? Absolutely. If you do your assessment and you use your critical judgment, or critical thinking and your clinical judgment, right? Look at your patient. Your alarms are telling you they're going off for a reason. Why are they going off, right? Why is a normal, healthy kid desatting due to constipation, right? That's not an okay thing. If you're concerned and your physician doesn't seem concerned, go above them, right? Tell your charge nurse, I talked to my physician, this is what happened, I'm still not comfortable with what's going on, right? Call a rapid, get other people there, right? You're gonna get house soup, you're gonna get a whole bunch of other help that are gonna look at that kid and be like, yeah, something's going on, this is not constipation, right?
Would we get in trouble if we like, everybody was telling us like, no, everything's fine, and then like you didn't have that feeling, so you call it rapid?
No, absolutely not. And actually, we now have signs in the room for families to call their own rapid.
Yeah.
So if they are not happy with the care that they're getting and they think there's something going on with their kid and it's not getting addressed, the sign on the wall says, call this number and call a rapid. And you'll get more of a healthcare team here to reevaluate. It doesn't happen often that parents will do that, but they do have that option. Yeah. So absolutely not. Like if you're not getting the help that you think you need and there's something going on with your patient and it's just not sitting well with you, call a rapid. You're gonna get ER nurses, you're gonna get the house soup there, you're gonna get ICU nurses, right? And all of them are going to do their own assessment and be like, yeah, something ain't right with this kid, right? And so if you've got a physician who's just kind of, it's constipation because they're on narcotics, okay, well, no. There's other things going on, right? Like their alarms keep going down, like they're decompensating, right? This isn't okay.
Also, just to interject, pectus, either of those is not a minor surgery. It is a major surgery and it is extremely painful. And our kids go to the ICU after this surgery for at least a day.
Yeah.
So that makes that even more astonishing.
Okay. So, we've talked about pharmacokinetics. Kind of touched on that a little bit. So in kids, pharmacokinetics, again, is different than in any patient. Pharmacokinetics and pharmacodynamics are different, right? One is how they move through the body, and one is how the drug works in the body, right? So kinetics, how it moves through, dynamics, how it works. How it works does not change in any population, but how it moves through does, based on things like their immature renal function, delayed gastric emptying, they've got a higher total body water volume, they've got a higher metabolic rate, so they'll burn through that medication faster, okay? So there's a number of reasons why, or how it's moving through the body, it changes, okay? This one, depending on the route that you're giving, gives you kind of their developmental considerations. So if you're giving oral to like a toddler, you're gonna use a syringe, how to give it, those sorts of things, okay? Allow the child to choose which liquid to take the medication with whenever possible, but remember, limit their choices, right? Don't just say, hey, what do you want to take this with? Give them an option. Do you want to take it with milk or do you want to take it with water, right? 2 options for them, okay? Cool? All right, ready for some math?
Yeah.
Okay. So, you have 4 pencils and I have 7 apples. How many pancakes will fit on the roof? Purple because aliens don't wear hats. Okay? So, let's look at one of the things that we're going to do. We're going to look at 24-hour fluid requirements. So, this is crucial when we're looking at their 24-hour fluid requirement when it comes to IV hydration, right? Or just their hydration in general. So if they come into the hospital and we're looking at how much should they be taking in when it comes to their hydration status, this is going to give us that calculation, okay? So we've got 3 different, how do I say this? We're going to break it down into 3 different steps. So if your child weighs 3.5 to 10 kilos, if they weigh less than that, that is a NICU problem, and that is before they get to us. So we're not gonna worry about that, right? We're gonna start at 3.5 kilos, okay? So if they fall within that weight, they are gonna get 100 mLs per kilo, okay? If they weigh between 11 and 20 kilos, they're gonna get 1,000 from that first group there, right? From the first 10 kilos, see that? So it's 1,000 plus the 50 mLs per kilo for each kilo over 10 kilograms, okay? I promise we're gonna work this together, okay? So for children weighing between 11 and 20 kilos, an additional amount is added after the initial 1,000, right? So we know that if they weigh 10, we're gonna make this math easy. If they weigh 10 kilos, 100 mLs per kilo is gonna give you 1,000 mLs, right? So if they fall within this weight, and they're 10 kilos, they're automatically gonna get 1,000, right? If they weigh 3.5, you're gonna multiply that by 100 and you get 350. My math right? Okay. So if you then have to move into the next category, if they fall between 11 and 20, you're gonna have 1,000 from the first 10 kilos, and then your additional amount is gonna be calculated at 50 mLs per kilo plus that 1,000 from that first 10 kilos, okay? If they happen to fall above 20 kilos, we're gonna take 1,000 from the first, 500 from the second, and then multiply 20 mLs per kilo for the rest of their weight, okay? So we know that we got 1,000 there, 500 there, so it's 1,500 plus whatever's left here, okay? We're gonna work on this together. So, you got a kiddo who weighs 10 kilos, therefore we need to use 100 mLs per kilo for 24 hours, right? So, 1,000 kilos in 24 hours, right? Okay. So, when we're looking at the calculations, the two different ways that you might see this is how much they're getting in 24 hours, or what is their infusion rate per hour, right? So on the exam, be very, very cautious of what you're calculating for. It's either gonna be for the full 24 hours or per hour, right? So if we know for that first kiddo there, we've got 1,000 in the 24 hours, right? So what is your infusion rate per hour? You're gonna divide that by 24. So what's 1,000 divided by 24? 0.66 or 66? It's like 66.7?
Yes.
Okay.
41.6.
41.66?
Yes.
Okay.
If you're running out, 6, 7.
Okay.
7.
Oh gosh.
Okay. 41.7. Okay.
Okay.
This
What do you want
one.
me to do, Alex?
Dump the kids in the 6, 7, and 8.
Oh my gosh.
I'm so over that.
6, 7.
Literally rounds up together.
What does that mean?
Don't judge me or the actual wrapping.
Okay, so 41.666666, right? Okay, so you got 1,000 in the 24 divided by 24 hours gives you the 41.66666, right? However, your pump can only program to 3 digits, okay? So that is information you need to know. Your pump can only program to 3 digits, whether it's 2 plus the decimal place or you have a whole number, it's 3 digits. Because when you have a 1,000 ml bolus that your provider orders and you have to get it in an hour, does your infusion pump program to 1,000 mLs an hour?
No.
No, you have to infuse it at what? 999, because it only does 3 digits, right? So if we have this, right? This number here determines what you're gonna round to, so really this is 41.7 mLs per hour.
For these meds wise, we're supposed to round to the.
So this, we'll get there. This is for your infusion pump, right? It will not let you program anything beyond that because you've got your 3 digits here, right? your pump will only let you do to the 3 digits. So that's where I said, knowing that information, your pump is only 3 digits, right? So that's all you're gonna be able to program, okay? So if you had, and there's one we have later, but for the other meds, it will specify what you need to round to, okay? Actually, all of them will specify what you're gonna need to round to, okay?
And, sorry, I know you're talking about the pump, but is this generally what their fluid intake should be for the day? So would that count if they're not just getting IV fluids?
So if so this is kind of specific to their IV fluids, but it's very close to their overall, like if they weren't getting IV fluids, their oral intake should be pretty close to this, yes. So overall, in a day, they should have about 1,000 mLs. Whether they take it through their IV or they take it orally, this is what their fluid intake should be to maintain that normal hydration status. Yeah. But for this particular problem, we're just looking at their IV intake. Okay?
Well, we'll do 6, 7 months. I'll be
6, 7. I don't know.
Special?
It's something that kids these days are doing. I have no idea if it means anything in particular or just that. Okay, so the next one there, we've got a fluid intake for a kid who weighs 18 kilos, right? So we know automatically that we've got 1,000, right, from that first 100 mLs times their first 10 kilos, right? Then we have 8 kilos left over, so we're gonna do that 8 kilos times 50. 450? Is it 400? Okay. Okay, so then we got 400 there, right? So we're gonna add those together. So 1,400 mLs in 24 hours. Okay? So their first 10 kilos, we know that we're taking that 1,000, and then we had 8 kilos left over, right? Okay?
Go back to the other slide. So remember, for everything over 10 to,
Okay?
from 11 to
So
20, you had 50 for each kilo.
Yep.
You guys seeing that? Everybody's asking where that 50 came from.
Yes, that's where we did it. Okay? So really it looks like this. So if you have 3.5 10. Times 10. Through 10. Okay? Is 100 mLs per kilo. Okay? If you have 11 to 20, we're doing it at 50 mLs per kilo. And anything greater than 20, we're doing it at 20 mLs per kilo, okay? So, if for like this kid who's 18 kilos here, right? We're gonna take the first 10 kilos, so they're 18 kilos. We're gonna take away 10 here for this first group, right? Which gives us 8. So that next 8 is going to be taken from the next group, right? So we're going to multiply that times the 50, which is what we did here. Yes. Okay? Everybody with me? Yes. Cool. Okay. So then, your question there then was, what is your infusion rate per hour then? $58.3.
Yeah.
Okay. Okay. 58.3 mLs per hour. Right? Can you program that into the pump? Just like that? Yes, absolutely. Okay. So, then our next one is for a kiddo who weighs 32 kilos. Okay? So, so we know that they're greater than 20 kilos, right? So we're automatically knowing that they get 1,500, right?
Yes.
Okay? So we got 1,500 already. Because we took 10 from here and 10 from here, right? So we got that, and then we've got 12 kilos left over. So 12 times your 20 is 240. 240. Okay. So then you have 1,740 mLs in 24 hours, right? So what's their infusion rate per hour? 72.5?
Yes.
Okay. Okay. So you got 72.5 mLs per hour. Okay. Now, for your child weighing 32 kilos, the physician has written an order that says you need to administer 10 mLs per kilo per hour in addition to their maintenance rate. So this is their maintenance rate, right? That is what they're getting per hour. So now you need to add an additional 10 mLs per kilo per hour. So they weigh 32 kilos, and we're going to multiply 10 mLs per kilo. Okay, gives us, so you don't have to do anything with the 24. It is just their weight times an additional mLs per kilo, right? So 32 times 10 is 320.
Mm-hmm.
Yeah.
Okay. Okay. In addition to their maintenance rate, right? So we now have 390.
2.5.
2.5. Thank you. Okay. Can you program this into the pump?
No.
This way? No. What does it have to change to?
393.
393. Right? Okay. So their new rate is going to be 393 mLs per hour. Okay.
Can you show me again how you got like the 10 from the first one and the 10 from the second one?
Yes. So you can look at this one here, right? So our kid weighs greater than 20 kilos because they weigh 32 kilos, right? So we know that automatically 1,500 is what they're gonna get. So they're gonna get 1,000 from here and 500 from here, okay? Because their first 10 kilos, right, we're gonna take, and so that leaves us with 22, okay? So their first 10 kilos comes from here, their second 10 kilos comes from here, so they're gonna get 500 from here, and now we're gonna take another 10 away, and that leaves us with 12, okay? So that 12 kilos is what we're multiplying to here, okay? Cool? Everybody good? Okay. Okay. Body surface area. Okay. So this one is probably the easiest one we are going to do. Okay. Everything will be converted for you. You're not going to have to go from pounds to inches or anything like that. Right? As long as you know how to do the calculation and plug it in, you're going to be good. Okay? So BSA is taking their height times their weight, dividing it by 3,600, and doing the square root. Okay?
Yeah, that seems easy.
It is easy, right? It is easy. Okay. So you have a child who has been prescribed chemo. In order to properly calculate, you need to do their BSA. Okay? So their BSA is their height times their weights divided by 3,600 and taking the square root of that. Okay? So their height is 130. okay? And their weight is 27 kilos. Okay. Huh? You're not gonna have to convert anything. It will already be in everything that you need. Okay? So this is centimeters, and that's kilograms. Okay? So you're gonna do 130 times 27. Hit equal. Then you're going to divide that by 3,600. Hit equal. And then hit your square root button.
0.
You have to turn your calculator, if you're doing it on your phone, you have to turn it sideways to get your square root.
And you also can change it to the scientific calculator.
Okay? The calculators that we have, they don't have one. So the ones that we will use for the exam that you use for all of your dosage calc, it has the square root button on it. Okay? Okay? So on your phone, it's going to be your square root.
I got 0.98.
Do we have that option in the calculator?
Yes, so the calculators that we use, so yes, so you're gonna do the 130 times 27, hit equal, then hit divide by 3,600, hit equal, and then it's the little checkbox, or the little check mark button, okay? You do not have to do anything beyond that. Once you hit the square root, that is your answer.
So 0.987.
Should be 0.987. Is that what you got? Is that right? Okay. So 0.97.
No, it's 0.975
So
before the square root.
we round to the 100th for BSA. So that's your second decimal there. So really,
0.99.
this becomes 0.99. Okay? Good? Okay.
Is there gonna be math on the quiz?
There's not going to be math on the quiz. The math will be on the exam. Okay? Okay. Do you want to go through the other two, or is that good?
What is the like unit of measurement for this? So we should just put
It's
0.99.
great question. So it's meters squared.
Meters squared.
Okay. For my exams, you are going to enter the number only, no label. Okay. So you will only enter 0.99. Okay. You do not have to add the meter squared. And it is very specific on the exam what you need to round to, and that you're not going to use a label. Okay. Cool.
Yeah.
All right. You want to do the other two?
Yeah.
Okay. I know we're running out of time, but I want to make sure that we get through. Okay. So for your next one, you've got a kid who's 102 centimeters tall, right? And they weigh 16 kilos. Okay.
Wait, what do you get?
So you're going to do 102 times 16, hit equal, then divide by 3,600. Okay. Once you've divided by the 3,600, hit your square root, and that's what you need. Okay. So it should be 0.673. Right? But we round to the 100, so really this becomes what?
6.
Ah, gotcha. Okay, 0.67. That 7 doesn't change. Okay, make sure you know your rounding rules. Okay, the biggest thing that will get you is that you leave off the 0. Don't do that because that's wrong. If you leave a 0, so say this was 6, 7, 8, right? Yep, just kidding. 6. Okay. If it's 6, 9, 8, okay, what does that round to?
0.7. Yeah.
0.7, right? Because this rounds up here to 7. Okay? Okay? Do not take this and also round this to a 0. If you give me 0.70, it is wrong. We don't do a trailing 0, but we need a 0 in front. Okay? Cool? Enough. You'll get a blueprint. Right? You will get a blueprint of how many math questions are on there. Okay? It will break it down into the different, how many questions are coming from what section and what module. Okay? Okay, so if you have to leave, you can leave. Otherwise, I want to try to get through the dosage count because I know we're right at time. But so for the dosage count, you got the physician orders cefepime, 900 milligrams IV every 12 hours for a patient with a ruptured appy and an abdominal abscess. The nurse identifies that the patient weighs 43.64 kilos. Your resource states that the safe dose is 25 milligrams per kilo per day. What is the max safe dose of cefepime every 12 hours? Round to the nearest 10, right? So you've got a kiddo.
It's
43.64. Your kid weighs 43.64 kilos, okay? And your safe dose manual says that it is dosed at 25 milligrams per kilo per day. Okay? So, 43.64 times 25 is what? Oops. 1,091, right? So 1,091 milligrams per day. Okay? But this is asking every 12 hours, right? So what do you need to do with this? Divide by 2, right?
every 12.
So it should be 545.5 milligrams every 12 hours. Okay? So, your resource is given it to you per day, but your physician ordered it every 12 hours, which we know that's 2 doses per day, right? So if this is per day, we're giving 2 doses every 12 hours. Our max safe dose should be this, right? So if you had that order, what would you do? Call your physician, right? Because they ordered 900 every 12 hours, but your resource says that your max is only 545.5, right? So accurate calculations, right? So in simulation, I want you calculating everything, okay? Your resource is stated in the chart. It will tell you what your safe range is, okay? So before you give anything in simulation, you need to be calculating it. Cool? Okay. So this is if you're just getting one single dose, right? So that is just telling you that is it. That's what's safe, right? Anything above that is not safe because you're overdosing. Anything under that is not safe because it's not therapeutic. It's not going to treat the problem, right? Because it's not a big enough dose to treat the situation going on, right? Okay, so then your next one says that you got a 5-year-old who weighs 15.28 kilos. okay? And they are gonna get a loading dose of phenobarbital. The physician ordered that dose of 270 milligrams IV once stat to be given. You identified that the dose for phenobarbital should be between 15 and 18 milligrams per kilo per dose, right? So we're going to do it 15 and 18, okay? And that's per dose, okay? It's then asking you, what is the calculated max safe loading dose for phenobarbital sodium, round to the nearest 10? So, it's only asking for the max. Do you need to do the minimum? No. Do you need to do the max?
Yeah.
Yes. So 15.28 times 18. 275.04, right? And it says round to the nearest 10th.
No.
275.04, right? Okay, but rounding to the 10th is this one. Okay? So, is that correct? No. Good. No 0. It's just 275. Okay? Cool?
This is how they're gonna look like.
This is what they're gonna look like. So you're gonna see that there's just 1 milligram per kilo per day, that there's a range, and it's gonna ask for either the safe max or the min, or the next one, what is the safe dose range? Okay? So you've got a kiddo who weighs 9.09 kilos. Okay? And they are post-op. The physician ordered cefoxitin, 140 milligrams every 6 hours. It's dosed at 30 to 40 milligrams per kilo every 6 hours for 24 hours after surgery, right? So times 30, times 40, okay. Gives you what? So your minimum should be 272.7, and your max should be 363.6. Yeah? Okay? So your safe dose range is going to be 272.7 dash 363.6. Okay? So when you enter that in, you are going to just do the number dash number. No spaces. Okay? Number dash number. Cool?
And so because the physician ordered the 140, technically, we would say that that's not appropriate because it's not reaching
Absolutely,
the potential
right?
of what it
So
should
you don't need to do anything else with the problem because this is what I was asking.
be. Yeah.
If you were doing it in practice, because the physician ordered 140, it falls below that, right? So it's not safe because it's not therapeutic enough to be effective to do what it needs to do. So you would question that, right? But for this, all you have to do is just do the calculation, right? Even though the dose doesn't fit within that range, okay? So don't get hung up on that piece. Okay, just do the math of the problem.
But for like simulation, like you said, we're gonna have to do all this
Yeah.
stuff.
So if you did this in simulation and that was the order, I would hope you would stop and say, hey, this dose is not correct. What do I need to do? Right? And then we're gonna work through that. Cool? Awesome. Thanks for attending today's lecture. Okay. Sorry we went over a little bit. I know